Thank you, Angie. My name is Sarah Bowman. I'm a principal in PYA's Knoxville office, and I work in the Revenue and Compliance Advisory area. And when I'm not working on projects specific to 340B, I also serve clients with various matters related to regulatory compliance, coding and billing, documentation, as well as managed care related work. And I'm really excited to co-present with Katie today. So Katie, I'll pass it to you for an introduction and to kick us off.
Thank you, Sarah. And my name is Katie Garmon. I'm a consulting manager. I'm with PYA and also work in our Revenue and Compliance Advisory Services line with Sarah. I do a lot of work in the 340B space and then also pharmacy related work, non-related to 340B. So whether that's billing and documentation review or general advisory for pharmacy operations. I also work heavily in the due diligence space, specifically related to private practices and physician groups, and then also work with a number of hospital employed medical groups on operational and financial advisory work. So with that, we will get started on our presentation. As many of you know, there have been a number of news articles and things you may have seen about the 340B program here recently. There's been a lot of movement in this space. Historically, 340B has been a bit of a gray area. There's not a lot of mega guidance that's come out related to this program. And so I think it's been a learning process for a number of covered entities and for us as consultants as well. So we're going to start today with just an overview of the eligibility requirements related to the program and how entities become eligible for the program and register. Then we're going to talk a little bit about what pre-COVID-19 compliance requirements look like. We'll talk about the public health emergency and the flexibilities that were extended as part of the COVID-19 public health emergency, and then what we all need to be thinking about post-public health emergency, so what's changed since the end of the PHE in May. And then we'll wrap up with just a few of the recent industry events and activity that have taken place within the 340B program space. Sorry. So the 340B program, what is the 340B program? It was created in 1992 by President Bush, and it requires drug manufacturers to provide covered outpatient drugs to eligible covered entities, or CEs, as you'll hear us refer to them throughout the presentation, at significantly reduced prices. And as a result of this, those CEs will benefit from the difference between the drug's reduced cost and the unadjusted reimbursement received from payers. The program was established with the intent of those CEs using the savings that they realized through the program to provide additional community benefit to patients who are uninsured or underinsured, or pursuing other community outreach opportunities using those savings as well. So in order to participate in the program, CEs will have to meet eligibility criteria based on their entity type, which Sarah is going to cover in a little bit more detail to come. But ultimately, those CEs are responsible for ensuring ongoing compliance with the program. And there is an annual attestation process that has to take place where each covered entity attests that they have met the requirements for the program through their annual recertification. Non-compliance can result in repayment to manufacturers if there are billing issues identified, or termination from the program. So why is the 340B program so important? The key here is going to be the discounts that covered entities receive. So in this graph, you'll see that that orange bar there is 340B pricing as it relates to other drug pricing that you'll hear throughout the industry. On average, 340B pricing is about 51% lower than the average wholesale price, so about half of the average wholesale price. The average wholesale price is the average price that wholesalers use to sell medications to providers, but this is not really a true representation of actual market price. It's honestly really comparable to the sticker price if you're looking at a car. It's an elevated drug price. It's rarely what is usually paid. It's not a government regulated figure. It doesn't include any buyer or volume discounts or rebates, which can often come into play when you're purchasing drugs. And it's subject to manipulation on a regular basis by both manufacturers and wholesalers. On average, 340B pricing is 23% lower than the average manufacturer price. This is the price paid by wholesalers for drugs distributed to the retail class of trade, net of customary prompt pay discounts. This price is statutorily defined and it's calculated based on actual sales transactions. You'll also see that 340B pricing is about 15% lower than group purchasing organization pricing or GPO pricing. As you know, of course, the core function of a GPO is to pool the purchase of common goods or services, or in this case, drugs, across numerous buyers, which creates purchasing power well beyond what any single entity could attain. As a note, though, for this program specifically, there is a statutory prohibition against obtaining covered outpatient drugs through a group purchasing organization or other arrangement for disproportionate share hospitals, children's hospitals, and freestanding cancer center hospitals. So many covered entities enrolled in the program wouldn't be able to purchase at GPO rates regardless of this pricing impact. So as you can see here from the graph on this slide, the 340B program is important in helping CEs receive discounted drugs so that they can pass those savings along to uninsured or underinsured patients, which is ultimately the intent of the program. So HRSA continues to have an increased focus on compliance related to the 340B program because of its significant impact and scope. So for calendar year 2021, total 340B program drug sales reached $43.9 billion, so almost $44 billion, or about 7% of the total US drug market. As of January 1st, 2022, participation levels include over 13,000 covered entities and almost 40,000 associated sites, for a total of 53,146 registered sites. So a lot of growth there as well. And then for fiscal year 2023, there's been an additional $7 million allotted for budgetary funding related to the program. And that funding has the goal of expanding program integrity efforts and increasing audit and oversight from HRSA. So now, noting the dollars, associated with the program, as well as the number of covered entities across the United States, we have a polling question.
Terrific. Moderator, if you will bring up our first polling question this morning in this session. How would you rate the resources, funding, and oversight currently available and allocated to the 340B program? Excellent, good, fair, or poor? You'll have about 30 seconds or so to respond to the polling question. Once we have finished collecting responses or have a good number of responses gathered, we will show the results. Again, just as a reminder, you are answering the poll for CPE credit. And if you are having any trouble answering the poll, you can put your answer into the questions box, and our CPE reviewer will make a note of it that way. Moderator, if you could show the answers, I think we have a good number of responses.
Awesome. So it looks like the majority of everyone is saying good, and then fair, and then a few excellent and a few poor. So I will turn it to Sarah now to cover some of the eligibility requirements for the program.
Thanks, Katie. So I would say that those polling question results were probably aligned with what I would have expected, a little bit of a bell curve there. Certainly resources are better than they have been in the past, but still probably have some opportunity there. So now that Katie has walked us through an overview of the 340B program, I want to walk through some of the shifts over the past, over the past several years since the COVID-19 pandemic. But first, let's talk about some of the core registration and infrastructure elements of the program. Back in the good old days, pre-masks, pre-COVID-19, when everybody just kind of thought about face masks for Halloween, and not as something that you would have in your car at all times, or wear in the grocery store. So let's talk about that for just a moment here. So 340B program registration, this is one of the important components of the way that the program works that is oftentimes a bit misunderstood when folks are looking to either join the program initially or add contract pharmacy relationships or add registered child sites to their existing program. So covered entities have always been required to register with the Office of Pharmacy Affairs, or OPA. They maintain a pretty robust database of CE details. So it includes the hospital's physical address, their entity type, the registration date, and their last recertification dates, the name and title of the authorizing official, and it also lists out existing registered contract pharmacy locations and child site locations. And those are really important elements because you're really at that point saying, here's my entire, here are all the details of my 340B program, and HRSA is going to look to that if and when they conduct an audit of your organization to make sure that what you have given them in terms of the details of your program aligns with the way that your program is being operationalized. So the registration process was and still is a quarterly process. The next registration window that we're coming up upon quickly is in July. It's July 1st through 15th. So there are quarterly 15-day registration windows. July is the next one, and there's another in October and January, and then again in the spring and April. So during those registration windows, you can submit information as to, we want to make a change in our program, we want to add a contract pharmacy or add a child site, and then the effective date or the start date for whatever change is being provided to OPA would occur at the beginning of the following quarter following that registration date. So as you can see from the graphic on the slide to the right, this timeline for implementation can be as and it's really challenging sometimes for covered entities to plan for that. So it can be somewhere between 150 to sometimes as long as 210 days, depending on some of those processes and factors. So it's really important to plan ahead, understand what your strategies are as a covered entity, and be thinking about these timelines and windows when you're looking at making a change to your program. So here on this slide, we just give an overview, and Katie touched on this briefly, the various entity types, covered entity types for hospitals. So the 340B program is not just for hospitals. Federally qualified health centers, Ryan White HIV/AIDS program grantees, and then specialized clinics can also participate in the program. When we say specialized clinics, we're talking about Black lung, we're talking about Title X family planning, tuberculosis, hemophilia treatment centers, STD clinics. Those are the types of clinics that can also participate in the 340B program. But today's presentation is really going to focus on the specifics of hospital covered entity program participation. So nonprofit hospitals can be eligible to participate under, again, one or more of the following entity types. So pediatric hospitals, disproportionate share hospitals, which is a big bulk of the covered entity types, critical access, cancer, rural referral centers, and sole community hospitals. And so this chart kind of visually provides an overview of some of the similarities and then some of the core differences in covered entity types. And we do have some clients that are eligible under more than one of these criteria. So for example, a hospital may be eligible to register as a DISH hospital, but also as a sole community hospital. And so they may make the decision that it is more beneficial for them to register for 340B under their DISH status, even though that DISH threshold percentage is greater, so that they can, so that they will not have to be subject to the orphan drug exclusion, for example. So those little factors in the chart, the X's, are very important when you start thinking about how the program will be operationalized and meeting compliance with those core elements. So orphan drug exclusion, and then Katie touched on the GPO prohibition that is applicable for pediatric DISH and cancer hospitals. So just be mindful of those in terms of how your covered entity type is set up in on the OPA database. And in the time period before the public health emergency, pre-COVID, any clinic that was located outside the four walls of the hospital had to be registered as a child site to purchase or provide 340B drugs and participate in the program. We'll talk about that just a little bit more as this presentation goes on. So there have been, and you'll kind of notice a theme throughout today's presentation, there are all sorts of changes with the 340B program. There continue to be a lot of changes. It seems like if you subscribe to, Becker's and Modern Healthcare and some of those publications, it seems like every few days there's some sort of a breaking news alert. And so a lot of that industry activity and chatter really ramped up during this time period when we started seeing changes in billing requirements. So in January of 2018, CMS said, really as part of the Medicare program, we want some of the savings that are being realized by the hospitals. And so we're going to reduce the reimbursement. We don't think that those covered entity hospitals should be getting the regular reimbursement for separately payable outpatient drugs. So we're going to require the use of some modifiers and through those modifiers make payment adjustments. So they instructed the use of modifier JG, which triggered the payment adjustment, and the use of modifier TB, which was informational at that point. So, and at this point, it was in 2018, non-accepted off-campus provider-based departments were able to bill with the modifier TB and were not subject to that payment reduction that the hospitals were feeling. But the adjustment and reimbursement that the hospitals were subject to was quite significant. So historically, Medicare's reimbursement for separately payable outpatient drugs, whether they were obtained under the 340B program or not, they were paid at ASP plus 6% or average sales price plus 6%. And this change transitioned that to ASP less 22.5%. So it was almost a 30% haircut in reimbursement. Definitely significant for covered entities. No one was really surprised by the fact that hospitals challenged this rule, and a bit of a legal battle kind of started to take shape. In 2019, CMS said, okay, for those non-accepted off-campus provider-based departments, we've taken a look at the volume there, and instead of reporting that informational modifier, the TB modifier, we want you guys to go ahead and report the JG modifier as well. And so those provider-based departments were then subject to that same reduced reimbursement that the hospitals had been feeling from the year before. And as if those financial ramifications of that policy change by CMS weren't enough, a lot of hospital clients and covered entities struggled with operationalizing this change because it wasn't something that folks really anticipated. So we know of clients that made changes within their split billing software to help make this billing process happen. Others were reaching out to some of their endpoint billing systems to try to figure out what's the best way to do this. And we know even some, at least initially, were having to put some claims in queues and things to work through them in a more manual process until they could work out a more automated workflow. So it really was problematic in the beginning for covered entities, not only from a reimbursement perspective, but from just a day-to-day operational revenue cycle perspective. So the American Hospital Association, the Association of American Medical Colleges, that just rolls off the tongue, and America's Essential Hospitals, so those three groups went to court along with three 340B hospitals, and they claimed that the government didn't have the authority to make these cuts in 2018 or in 2019. And this was, in the press quite a bit, but in June of 2022, so around this time last year, those groups were victorious. They were experienced a unanimous U.S. Supreme Court decision. The court agreed that the government had overstepped its authority in making those reductions in the first place, and because the agency failed to conduct a survey of what the hospital's actual acquisition costs were prior to implementing the cuts, that those cuts should not have been made, which was absolutely welcome news for all of the hospitals. So starting toward the end of 2022, you saw some activity related to claim submission and resubmission and kind of how things were going to be handled on a go-forward basis. Interestingly enough, that victory, if we want to call it that, also served as a trigger for some covered entity clients. So there were some covered entities that, you know, kind of looked at this as obviously as a win for them from a reimbursement perspective, but it also served as a trigger for them to go back and look at, okay, how were our claims being submitted and how are we getting paid before? So how are we getting paid from that period of 2018 through 2022? And so we are aware of at least a number of covered entities that during these internal processes and discussion were not correctly appending the JG modifier always when they needed to, when it was required prior to the change that went into effect at the beginning of this year. And so the result was that those claims had been overpaid by Medicare, and the overpayment analyses for these covered entities were sizable in some cases. In some instances, covered entities were appending the modifier sometimes, but not always. Some of those were slipping through and missing the appropriate edits and such to have the JG modifier added. And in some instances, there were periods of time where the JG modifier wasn't being appended at all. So we are aware of at least one covered entity that had a repayment obligation that was about $10 million that was handled, obviously with the assistance of legal counsel, but just serves as kind of an example that we wanted to include here as to the importance of doing some of those routine internal auditing and monitoring steps of your 340B program components so that you don't get hit with a surprise, an unintended surprise down the road. All right, I'm going to talk quickly about the new guidance. So going forward, as I mentioned, Medicare is going to reimburse 340B hospitals for Part B separately payable outpatient drugs at the same rates that were paid to the non-340B hospitals, that ASP +6. And just be aware that the JG modifier is definitely still being reported, but is for informational purposes at this time. It's no longer tied to an adjustment in payment. The other entities that were not subject to the JG modifier before, so community hospitals, children's hospitals, and cancer hospitals should continue to use the TB modifier. All other hospitals that are being paid under OPS should continue to report the JG. And so with that, I'm going to turn it to Katie to talk with us about some of the flexibilities that were extended during the public health emergency.
Thanks, Sarah. So during the pandemic, obviously there were some flexibilities that were extended, and we're going to cover those in detail. As we reach the end of the public health emergency in May, this means the end of any federal regulatory waivers and flexibilities that were provided. And so providers were asked to roll back policies and practices implemented in reliance on those waivers and flexibilities. So we'll talk a lot about what those flexibilities were, and then also what covered entities need to be thinking about post-PHE and how those considerations may impact their operations and compliance efforts. So during the pandemic, like many in the healthcare space, HRSA actually set up a COVID-19 resources page and encouraged their covered entities to reach out to the Prime Vendor Program with any concerns regarding compliance. They really showed no real leniency as far as auditing efforts. So while they weren't doing in-person audits, they were still doing a number of desk audits during the pandemic. And we've heard that they've continued now post-pandemic to do those desk audits and come in person. Some covered entities did push unsuccessfully for a few flexibilities that I just wanted to note. So one of those was related to the GPO prohibition, which I mentioned, and Sarah covered again some of those entity types subject to that prohibition, but no waiver or flexibility was ultimately extended in relation to that. As HRSA stated, they did not have the authority to waive those statutory requirements. Instead, covered entities during the PHE were encouraged to maintain a log if and when they did have to purchase a 340B drug, not on 340B pricing. They were instructed to try and obtain that drug at the WAC or a wholesale acquisition cost. If it was unavailable at the WAC, they could then move to using GPO purchasing. This did not have to be reported, but did have to be addressed in the covered entities policies and procedures. Many providers also voiced concerns about maintaining DSH percentages needed for eligibility. So Sarah covered those eligibility requirements. Many were concerned that due to changes in volume in business related to COVID-19, they might not be able to meet those DSH thresholds on their cost reports. HRSA did note at that point that they lack the authority to make those changes, but as you'll hear herein, the Consolidated Appropriations Act that Sarah is going to cover ultimately did make some changes that allowed for continued program eligibility despite not meeting the DSH threshold for those entity types. So we're going to cover the flexibilities that did get extended from HRSA during this process, including entity and child site registration, provider definition and subsequent medical record documentation, and then overall program eligibility for certain entity types. But before we dive into those flexibilities and unwinding those as the public health emergency ends, we do have 2 additional polling questions.
Terrific. Moderator, if you will open up the polling question. Did your organization take advantage of any of the flexibilities extended during the public health emergency related to 340B? Yes, no, or unsure. We'll allow a little bit of time in order to answer the poll for CPE credit. As a reminder, if you're having any trouble answering the polling question, please put your problem or the answer to the question within the questions pane, and our CPE reviewer will track your response there. We'll allow just a couple more seconds before we release the poll back to Sarah and Katie. I think we look good. Moderator, please release the poll.
Okay, perfect. So it looks like a number of people did, about a little over 30%. There are some who are unsure if those flexibilities were taken advantage of, and then it looks like about 18% did not take advantage of any of those flexibilities. And that will actually lead us right into our next polling question, which is about the specific flexibilities.
Wonderful. So moderator, if you will release the next polling question. If so, which flexibilities did your organization utilize? Choose all that apply. Entity and child site registration, provider definition and medical record documentation, overall program eligibility, none, or unsure. Thanks to our attendees for answering the poll quickly. We've got good participation so far. And again, if you have any trouble, please just put your troubles in the questions pane and we'll follow up on that afterwards. Also, if you have any questions for Sarah and Katie, they will follow up with you after today's presentation. Please feel free to put those questions into the questions pane. Moderator, if you'll release the poll.
Awesome. Thank you very much for all those responses. So it looks like there was a bulk of those who may not be sure which flexibilities were taken advantage of, and that's fine too. There's, not a lot of concrete guidance on some of these, but it does look like a number did take overall program eligibility requirements, which we will talk about there. I'm assuming that's related to the DSH percentage threshold flexibilities. And a little under 10% who took advantage of entity and child site registration flexibilities and those provider definition and medical record documentation flexibilities. Awesome. So we'll start by talking a little bit about entity and child site registration. So we've talked about this a bit, but prior to the pandemic, all covered entities, child sites, and their contract pharmacy arrangements were required to register with the Office of Pharmacy Affairs, or OPA database, during one of those designated registration windows that Sarah noted. And this registration process, again, typically took anywhere from 150 to 210 days, with participation effective dates aligning with the beginning of the following quarter. So if you think about that from a timing perspective, approximately 3 months post-registration window is when any of those covered entities, child sites, or contract pharmacy arrangements would have their participation effective. So in light of COVID-19, HRSA did allow some organizations, specifically upon request and review, to enroll in the 340B program without going through the enrollment cycle. So this would be specific to covered entities. They could enroll in the 340B program outright without going through the enrollment cycle, as long, again, as they had gone through the request and review process. In order to communicate about those additions, a supplemental Medicaid exclusion file was posted every Friday, and that did outline those new covered entities added through the flexibility. In addition, both new and existing covered entities were allowed to add and enroll off-site outpatient clinic child sites without having to wait for the registration window and subsequent start dates. So as soon as the child site was deemed eligible to be listed on the covered entities Medicare cost report, it was eligible for enrollment. This flexibility granted covered entities and their child sites immediate access to drug savings through the 340B program rather than having to wait through some of those prescribed timelines. So as the PHE comes to an end, any covered entity that enrolled during the PHE should make sure, of course, that they understand and adhere to all of the requirements for recertification. So some of them who did enroll during the pandemic may not have come upon their recertification process, and so wanting to make sure they agree with everything within the attestation and that they've got everything ready to recertify. If you did register child sites during the public health emergency, those should be registered on the OPA database as soon as possible using that pre-pandemic registration process. And we do recommend that you do confer with 340B specific legal counsel if you are continuing to dispense at locations that are not yet registered on the OPA database post public health emergency. Covered entities should again continually monitor their program eligibility. And again, Sarah is going to speak a little bit about that as it pertains to DSH percentages. And if you are contemplating adding any new child sites or contract pharmacy arrangements today or going forward, you should revert again to pre-pandemic registration. So identify that appropriate registration window within the table and plan for those future start dates that again are typically about 3 months post-registration window. So as I mentioned, HRSA also extended some guidance and flexibility related to the provider definition and subsequent medical record documentation. So in light of COVID-19, many covered entities did expand their provider definitions to meet fluctuations in care needs. And so there were a lot of volunteer health professionals that may have been assisting and delivering care in different settings. So HRSA did require emergency documentation that clarified the relationship between that provider, so perhaps a volunteer health professional or other, and the covered entity. And HRSA also understood that because of the pandemic, there were some providers, particularly those who may not be typical employees of the entity, that may not have had access to full histories or patient insurance information or other demographic data. So in response, HRSA did issue some guidance that said an abbreviated health record would be adequate for purposes of documenting that patient and provider relationship, and also the covered entity's responsibility for patient care as required by the 340B program. At a minimum, that abbreviated health record was required to identify the patient, record the medical evaluation, and then also outline the treatment provided or prescribed. So now that we're post-PHE and covered entities are returning to pre-pandemic operations, firstly, you should review your provider definition and update it as needed, or remove provider types that may have been added during the pandemic that no longer meet that definition. So for example, if you revised your provider definition to include volunteer health professionals and you're no longer using those or not in the volumes that you were during the pandemic, you may consider revising that provider definition within your policies and procedures so that it is adequate and up to date. Your prescriber listing should also be regularly reviewed. I'll add that we recommend that you do review this on a quarterly basis, regardless of pandemic or otherwise. But if you did add any providers to your eligible prescriber listing during that period that are not currently on that or that have left, that should be communicated to all of your contract pharmacies and any applicable split billing software vendors, so that there are no dispensations made under those prescribers that shouldn't be qualifying. Many covered entities also updated their policies and procedures. I mentioned a few areas where they should have updated policies and procedures based on HRSA's guidance. So anything that you changed during the pandemic should be reviewed to note the effective date of revised procedures, so during COVID-19, and then the return to pre-pandemic requirements. And then finally, again, after May, we need to make sure that medical record documentation is now sufficient to meet the pre-pandemic expectations from HRSA. So making sure it's no longer the abbreviated health record we're relying upon, but something that meets all of those requirements, and that all of those records are maintained in an auditable manner, which is one of the things that you do attest to as part of your recertification process. So with that, I will turn it to Sarah to talk about some of the program eligibility flexibilities.
Thanks, Katie. So in March of last year, President Biden signed the Consolidated Appropriations Act 2022. And while this act had many important components to it as it relates specifically to 340B, it provided protection for the 340B covered entities that may have been on the cusp or at risk for losing their 340B status due to changes in patient mix and volumes related to COVID-19. So this protection was extended to hospitals that had already lost their eligibility due to falling below the DSH threshold. So for example, a DSH hospital that had fallen below the 11.75% that we talked about earlier, or an RRC, for example, that had fallen below that 8% requirement. The provisions extended to DSH, children's and cancer hospitals, RRCs, as well as sole community hospitals. But to leverage this COVID-19 waiver to protect covered entity participation in the 340B program, the covered entity had to meet some specific requirements. So they had to have a termination that was related to COVID-19, either actions taken by or the hospital's response to. And the hospital had to have been a participating covered entity prior to the start of the public health emergency. So they had to have been participating already in the program on January 26th of 2020. So for a covered entity, for example, that may have started their registration process during COVID and then maybe fell off due to not meeting that threshold, they would not be eligible for taking advantage of this waiver. The protection helped lock in, so to speak, that eligibility through the end of 2022. So it kind of maintains that required DSH threshold for hospitals that have that as an applicable part of their compliance as a placeholder, an interim placeholder is kind of the way, a good way to think about it. So to obtain this protection, as I mentioned, hospitals had to attest to HHS as to how COVID-19 had impacted their organization and how it had impacted their hospital's ability to meet those program requirements. If the hospital had already lost their eligibility, they had to submit an attestation within 30 days of the law's date of enactment. So there was a deadline of April of last year, April 14th of last year. And then if the hospital expected that they were going to be losing their 340B covered entity status when they filed their new cost report, an attestation to that effect had to be submitted within 30 days of filing that Medicare cost report with the lower DSH percentage. So we are aware of clients that have absolutely taken advantage of these protections. I think we saw that in our polling results as well, that was one of the things I think was the largest bar on that particular poll, is the flexibility that was taken advantage of that really helped covered entities. We are also aware of clients that have evaluated transitioning their covered entity type. You remember me talking about earlier in the presentation about how covered entities that fall under more than one criteria can kind of pick the way that they want to register with OPA. Oftentimes there are instances where if a DSH hospital is no longer able to qualify for 340B under DSH, they may evaluate whether or not they meet the requirements under another covered entity type, such as RRC, for example. So we are aware of those sorts of strategic thoughts and activities happening with covered entities. So this was a really important flexibility. All the flexibilities have been important, as Katie mentioned, a number of them for hospital providers during COVID. But this one, I think, is one that from what we understand, was extremely beneficial for a lot of hospitals that would have otherwise been at risk for losing their 340B program savings at a time when they're already getting hit with so many other things related to COVID. Oh, sorry about that. My child got a hold of my mouse last night, so it's a little glitchy on my end. I apologize. Overall program eligibility post public health emergency, we've gotten some questions as to, do we think that this waiver, these extensions and program participation will continue, or do we think that there might be an extension of such? And right now, that does not appear to be the case. Definitely would not bet on it. So covered entities other than critical access hospitals with no DSH percentage requirement will need to really closely monitor their eligibility and make plans accordingly. So if a covered entity anticipates that they might be losing eligibility because of not meeting that DSH percentage, you may want to consider reaching out to the 340B prime vendor. You may want to, if you haven't already, engage with local legislators on it. It may be a good time to evaluate a review of your Medicare cost report and really doing an audit to see if there are any potential missed days, missed opportunities for reimbursement there as it relates to meeting that DSH percentage. So just kind of doing some checks and balances there. And that's certainly something that we at PYA would be happy to help with if that's something that you need assistance with within your organization. Additional PHE, post-PHE, considerations. So we continue to see a movement from patients that were previously had traditional Medicare to Medicare Advantage plans. And this has ramifications for a lot of areas across healthcare, but definitely has an effect on 340B. Many of you are probably already seeing this in your payer mixes as well, or possibly have been for some time. We're noting that that's a trend really across the country. It's not specific or isolated into any particular state or market or geography. We're really kind of seeing it across the board. Some areas, obviously, it's more prevalent than others still. But this is really being felt by 340B hospital providers because Medicare Advantage DRG payments are not included in the DSH calculation as eligible DSH days. But those do count toward the denominator of the Medicare low income equation. So in addition to that, it may also impact the hospital's SSI percentage because potentially fewer Medicare Advantage patients could be SSI eligible, which reduces the number of DSH eligible days in that equation as well. So we're seeing activity in that space. We're seeing providers kind of taking a look at their Medicare cost reports, trying to evaluate and make sure that they're capturing everything, that they haven't missed anything as it relates to their capturing of days and Medicare cost reports. We're also seeing a number of providers reevaluate clinic sites. So provider-based status has kind of dwindled in popularity, but we are seeing a bit of a pickup of just having some conversations, doing some financial modeling, taking a look at strategy as the organization grows to say, okay, are there clinic sites that we should consider becoming provider-based? For clinic locations that are outside the hospital's walls, generally the requirement is that they need to be listed as reimbursable on the hospital's Medicare cost report for child site eligibility in the 340B program. And so we are seeing hospitals and health systems begin to kind of open this back up as a potential for expansion to gain the benefit of 340B pricing for those locations. And then just like many of us have returned to in-person work, concerts, travel, social activities, HRSA is also returning to in-person audits. They're not going to continue to only do desk audits. So something to be aware of for your program as you're planning and looking ahead. So I want to pivot for a moment and talk a little bit about recent events and industry activity. 340B just continues to be full of change. Even this week, as we were preparing for this presentation, a couple of days ago, there was a state law change for the state of Louisiana. So we just continue to see things happening related to 340B. So now that we've talked about some of the PHE related changes and post-PHE considerations. We'll talk a little bit about what's happening, this year. We touched on this a little bit earlier, but so the 2023 OPS final rule, outpatient prospective payment system final rule, included essentially that hospitals that are participating in 340B and getting that 340B savings will be paid the same as hospitals that are not participating in 340B when it comes to those separately payable outpatient drugs. And that really stemmed from the Supreme Court's decision to strike those payment cuts. And then, as we talked about previously, that the JG modifier has shifted such that now it does not impact payment. It's just used for informational purposes. But it's still important when you're thinking about your program's compliance. It's still important to take a look at your billing processes, make sure that you're submitting that modifier when you need to. So it's a good idea to kind of take stock of some of these activities. Make sure you are submitting claims the way that you need to be to evaluate compliance with that requirement. Other interesting and maybe not as exciting things that are happening for covered entity clients, we continue to see a lot of activity, troubling activity related to contract pharmacy restrictions. Many are coming from major brand name drug companies. And so at present, we're aware of restrictions that are coming from more than a dozen drug companies related to the use of 340B acquired drugs acquired at 340B pricing being restricted from being used at contract pharmacies. So if you are a 340B covered entity and you have contract pharmacy arrangements, you have a bill to ship to situation where you are paying for the 340B priced drugs, and then those drugs are being shipped to, Walgreens, Rite Aid, wherever your CVS, wherever your contract pharmacy locations are. And so we're seeing a number of organizations, a number of manufacturers that are cracking down on that. So Bristol Myers Squibb, Eli Lilly, Novartis, Novo Nordisk, United Therapeutics, AstraZeneca, Sanofi, AbbVie, Johnson & Johnson, Merck, Pfizer. So really your heavy hitting players in the market are trying to crack down on that and make it more difficult or limit the ability for covered entities to do that. And so this restricted access is really happening in a couple of different ways. So some are outright denying 340B pricing. They're picking up on that bill to ship to arrangement that I mentioned. And so if items are being shipped to a contract pharmacy, the drug manufacturers are saying, no, that's, we're not going to allow 340B pricing for those purchases. We are seeing restrictions that are tied to contract pharmacy dispensation data. So some are requiring covered entities to report de-identified dispensation information as to what volume of what scripts are going as part of their 340B program. That data submission process is going through the 340B ESP is the tool that's getting reported through. So that is really, of the restrictions that we're going to talk about, while it is an administrative burden for covered entities, it's probably the least bad, the least of them in terms of considerations, as it doesn't yet limit financially the purchase of those drugs. It's just, hey, we want to collect all of this data from you. The other restrictions that we're seeing are occurring where a drug manufacturer may say, okay, you've got 10 contract pharmacy arrangements. You can use one of those for our drugs. So Johnson & Johnson, for example, might say you can use CVS, but you can't use Walgreens and Walmart and Rite Aid. You can only use that one single contract pharmacy, and that only we're noticing that that's happening for those without an in-house pharmacy. So if you have an in-house pharmacy, there may be additional restrictions that they are trying to impose there. Interestingly enough, HRSA's website does have a notice on it currently. It's just as titled, it's just a notice regarding recent court rulings involving the 340B program, it doesn't list any specific pharmaceutical manufacturers on it, but it just states that they're pleased with 2 of the 3 recent U.S. District Court opinions, that that those opinions agreed with HRSA that the drug manufacturers had unlawfully restricted access to discounted drugs, and that they shouldn't be doing that as it relates to their contract pharmacy arrangements. And then that they disagreed with the court opinion that found that there were 2 other manufacturers that had not violated that statute. So it'll be interesting to see kind of how this continues to evolve, particularly as states start to become really involved in this issue as well. So I mentioned changes for Louisiana. So 2 days ago, the governor of Louisiana signed state level protections that actually were developed by the American Hospital Association. So the Louisiana law prevents drug companies from denying, restricting, prohibiting, or interfering with the acquisition or delivery of a 340B drug at a contract pharmacy. And there is a similar law in Arkansas as well. Both are intended to help protect the restrictions that I just mentioned, so that covered entities can still leverage those savings at their contract pharmacy locations. And the Louisiana law goes a step further to also specify that a health insurance payer, a pharmacy benefit manager, or another third-party payer cannot reimburse a 340B entity for 340B drugs at a lower rate than others. And so they're essentially trying to kind of protect against what covered entities felt from a reimbursement standpoint when Medicare made its reductions from 2018 through 2022. So it's just interesting. The states are now starting to become really involved. It's great to see. It's unfortunate that it's coming to that, but it's good to see some activity there. In addition to the contract pharmacy restrictions that I just mentioned, there are manufacturer restrictions that are happening on 340B drug sales in general. So there are 22 manufacturers that are trying to restrict sales to offer drugs to 340B hospitals at the 340B ceiling price. They're trying to just not do that to begin with, regardless of whether it's associated with a contract pharmacy or not. Both federal district courts and appeals courts have determined that these restrictions are allowed under the 340B statute. It'll be interesting to see what happens there as we continue on. The flexibilities that Katie had discussed surrounding child site participation in the 340B program before being registered with OPA, those flexibilities that had previously existed, those have been taken down from HRSA's website. They're no longer out there. Our understanding right now is that in the event of a HRSA audit, you would want all of your participating covered entity child site locations to have current and correct 340B information out there on the OPA database. So that would include all your child sites, all your contract pharmacy locations. So as is sort of the theme for 340B, there are a number of considerations. There are a lot of different opinions out there about that in particular, because there wasn't really a warning or a tee up for, hey, this is changing. HRSA just took the information down from its website. So there are varying degrees of compliance risk tolerance within organizations. And so if your organization was one of those that answered our polling question earlier and took advantage of those flexibilities during COVID and is concerned about the ability of that child site that took advantage of that flexibility to meet program eligibility requirements going forward, we would definitely recommend that you seek guidance from legal counsel specializing in 340B to kind of help you work through that. I know we're getting close to the end of our time here, so I'm going to go a little bit quickly through these next couple of slides, but we definitely recommend to continue to look at some of your what we call infrastructure components of your program. So making sure that your policies and procedures are current. If there were changes to your child sites during COVID or post-PHE, that those are all accurately reflected. The OPA database items, that's really low-hanging fruit for HRSA, so make sure that those are being kept current. Obviously, any changes that have happened since COVID should be monitored. So if you have had changes in your eligible prescribers, changes in, hospital departments, outpatient hospital departments, provider-based clinics, all of those need to be monitored and updated accordingly. Oftentimes, the core elements of the program are done correctly and with good intent. Sometimes some of those changes, even within your split billing software system, can be the piece that causes something to qualify that shouldn't, or vice versa. So definitely make sure that you're looking at your eligible locations within your split billing software and your eligible prescribers. And then billing requirements, as I talked about earlier, those should definitely be reviewed regularly. Make sure that that's part of your 340B auditing and monitoring plan for your program. This slide just provides an overview of the things that you are attesting to when you recertify in the program, in the 340B program. So if you're the authorizing official, you're probably already pretty familiar, hopefully, with all of these items. If you're not, it's good to just be aware of this. So when you recertify to maintain participation in the program each year, these are the things that you are attesting to HRSA that you are doing, so that you are maintaining an accurate database registration, that you're meeting all of the eligibility requirements, that you're in compliance with program guidelines and requirements, that you're maintaining auditable records, so that in the event of an audit, you can produce whatever you need to support that dispensation, that you're maintaining documentation, and that your contract pharmacy arrangements are in compliance, and that you're going to notify the OPA of any significant changes, and then you understand that you'll be liable in the event of a breach. So it's good to just have those top of mind, again, as you're thinking about how to structure your program on a go-forward basis. I'm going to skip through this next slide. You can read that there, but just again, making sure that you have these items within your organization. And now it's time for our final polling question. Angie, I'll turn it to you for that.
Terrific. Moderator, if you'll open the poll. We have a little bonus poll here at the end today. Has your 340B program gone through an audit, mock, or HRSA, HRSA in the past 5 years? Yes, no, unsure? Yes, but longer than 5 years ago. And while you are answering this poll and we're collecting responses, please know as you exit out of the webinar today, there will be an opportunity for you to provide feedback to us related to this webinar. We really want your feedback and absolutely do learn from it. So as you exit, please answer that survey regarding our time today together. Moderator, if you'll close the poll, I'll turn it back to Sarah and Katie here.
Perfect. Thanks, Angie. So interestingly enough, 37% of our attendees today have had a HRSA audit or a mock audit in the past 5 years. So that's great. Looks like a number of you are unsure, and then some had, but it's been more than 5 years. So definitely anticipate involvement in audits will continue, and activity there will continue. Our team of PYA experts is ready to help evaluate cost report calculations, considerations related to provider-based status, and conducting 340B program assessments. And we would be honored to partner with you if we don't already for 340B. Thanks so much for being with us today. We hope that this presentation was really helpful to you as you think about your program compliance and forward-looking strategies. And this wraps up our presentation for today. So I'll pass this over to Angie.
Terrific. Thank you, Katie, Sarah. Thank you to all of the attendees for joining us today. We hope you come back tomorrow for 2 more opportunities for complimentary CPE to our CPA attendees. And again, we look forward to seeing you again. Thank you.